Well, thank you everyone for your patience. We'll go ahead and get started. My name is Sarah Gordon. I'm a pharmacy and academic fellow at the University at Buffalo. I'm currently completing my psychiatry rotation with Dr. Tammy Lee Dimler. And today I'll be giving a presentation that's primarily focused on Vivitrol, which is the injectable naltrexone. For the objectives include describing foundational concepts of both alcohol and opioid disorder, which will be known as AUD and OUDs. The reason that I'm discussing these two disorders is because they are the FDA-approved indications of Vivitrol. Additional objectives include explaining drug information of Vivitrol, followed by discussing key clinical trial data. The first part of the presentation will have primarily nursing-related data, but then I'll discuss more about the literature throughout the presentation. Before I go into the background, I have a question which I encourage you all to think about now and throughout this presentation. And that question is, relative to Vivitrol, what is your level of comfort and your experience with the following? As you can see here, depending on your role as a healthcare professional, your answers will vary.
Yeah, 1 second, it's not changing on here.
Correct. All right. So for those of you who just saw this screen, basically this is a question in which I encourage you to think about, essentially as you roll as a healthcare professional, what is your level of experience with the following when it comes to Vivitrol? One of the main goals of this presentation is by the end of it to have an increase in level of comfort and knowledge. With that, moving into the background, alcohol use disorder, or AUD, is the fourth leading preventable cause of death within the United States. In 2024, around 28 million people in the U.S. have a diagnosis of AUD. Of those 28 million people, there are more males than females. Also of note, less than 10% of patients with AUD receive treatment. There are a variety of reasons why this may be the case. This can be due to stigma, barriers to care, lack of access to transportation, cost issues, as well as low perceived need to receive care and lack of motivation to reduce alcohol intake. For OUD in the United States, over 6.1 million people have a diagnosis of opioid use disorder. In 2024, around 217 people died from an opioid overdose every day. This equates to around 80,000 deaths per year. It's not uncommon for patients who have co-occurring substance use disorders. Of those that have OUD, around 27% also have AUD. This slide here is to summarize the 3 FDA-approved medications for alcohol use disorder. I won't be going over all of this in depth, but I just want to highlight a couple key points relative to naltrexone. So if you look on the top row, you can see there's 3 FDA-approved medications, which are naltrexone, acamprosate, and disulfiram. All 3 medications are approved for moderate to severe alcohol use disorder. If you look on the dosage forms, you can see they all come in tablet form, and naltrexone has the intramuscular option. Patients may be appropriate candidates for naltrexone if they either have the goal of reducing alcohol consumption or the goal of achieving abstinence. In primary literature, patients who take naltrexone have shown to have a reduction in craving, relapse, and heavy drinking. As with any patient population, you always do want to consider patient-specific variables when deciding between medications, such as renal and hepatic function. For example, for patients with naltrexone, you do want to avoid if they have hepatic failure. Additionally, relative to the dosage forms, there have been reports of patients having greater adherence with the intramuscular naltrexone compared to the oral option. And again, the focus of this presentation is on the intramuscular naltrexone, which is also known as Vivitrol. This slide here is to summarize the 3 FDA-approved medications for opioid use disorder, which are naltrexone, buprenorphine, and methadone. Federally and within New York, naltrexone is a controlled substance, whereas buprenorphine is Schedule 3 and methadone is Schedule 2. As you see here, if you look on the second row, there are multiple different dosage forms that are available for each medication. Additionally, the mechanism of action does vary between these medications. Naltrexone is a full opioid antagonist, whereas buprenorphine is a partial agonist and methadone is a full agonist. It's also important to consider the setting in which patients may receive these medications. Naltrexone can be administered in any medical setting after patients have an appropriate opioid-free period, which I'll be discussing in more detail later on. Buprenorphine can be administered in an office-based setting or in an opioid treatment program. Methadone is restricted to opioid treatment programs. And again, the focus is on the I am naltrexone. Now, what is available at the Buffalo Psychiatric Center? I am curious for those in the audience or those in person, does anyone have any experience with naltrexone or Vivitrol, whether that's prescribing or administering it? Yeah, do you want to share?
So I've done it mostly at a different hospital, but I've prescribed Vivitrol a couple times, and I've done like a lot of Suboxone here too with the film.
Nice. So for those online, someone in the audience said that they have prescribed Vivitrol a couple of times. Naltrexone can be an option at the center, though it's not very common here. Additionally, as you can see, buprenorphine is available here at the Buffalo Psychiatric Center. If you look here on the box, you can see that there are multiple options that come in film and tablet form. Methadone, again, because it's restricted to opioid treatment programs, we do have restrictions here because we are not a narcotic treatment center. Now with that, I have a question for everyone. I do have some questions throughout the presentation based on the content that I discussed. I encourage those in person to share out loud, or those online if you want to put in the chat or speak through the microphone. So the first question is, which of the following statements is true? Is it A, naltrexone has both tablet and injectable routes of administration and is approved for AUD only? B, naltrexone has both tablet and injectable routes of administration and is approved for AUD and OUD? C, naltrexone is only available as an injection and is approved for AUD and OUD? Or D, naltrexone is only available as a tablet and is approved for AUD and OUD?
B.
All right, great. Yes, B is correct. As I mentioned before, naltrexone does come in tablet and injectable forms and is approved for both alcohol use disorder and opioid use disorder. So thank you. With that, I'm going to go into more detail about Vivitrol. As I mentioned earlier, Vivitrol is approved for AUD and OUD. Specifically, it's approved for moderate to severe AUD and mild to severe OUD. For alcohol use disorder, that received an earlier FDA approval. It was in 2026, whereas for OUD, that was approved in 2010. In terms of the regimen, Vivitrol is a 380 milligram intramuscular injection that is administered every 4 weeks. It is interesting to consider what is recommended on some drug resources compared to manufacturer. The recommendations do vary based on a patient should be abstinent from alcohol before starting. For example, if we look on LexiDrug, the recommendation is patients may be initiated on Vivitrol while they're actively drinking, whereas if you look on the FDA label and the manufacturer, they recommend that patients should not be drinking at the time of initial administration. I think what this shows is this is an example of what happens in clinical practice. It's not always the same as what is recommended per the manufacturer. And I think one of the reasons why the manufacturer recommended this, and I'll discuss this more later, but some of the key trials showed that patients who were abstinent from alcohol before starting the trial did have better overall outcomes with reduction in heavy drinking. Additionally, before patients are started on Vivitrol, they either have to pass a naloxone challenge or be opioid-free. The reason this has to be the case is to avoid precipitated withdrawal. In terms of the duration for opioid-free, usually it's recommended 7 to 10 days for short-acting opioids like oxycodone, and potentially up to 14 days for longer-acting opioids like methadone and buprenorphine. Additionally, if it's anticipated that patients may need surgery, you do want to discontinue the Vivitrol at least 30 days prior to surgery. Now, what is a naloxone challenge? Basically, this is a test to see if patients are lacking the opioid dependence before they start Vivitrol. As you can see on this slide, there are multiple routes of administration for the naloxone challenge, which include IV and sub-Q. Basically, what happens is patients will receive naloxone in the route that is given to them, and they'll be assessed if they have any signs or symptoms of withdrawal. Some things you can like alcohol withdrawal include anxiety, tachycardia, and agitation. If patients do have withdrawal symptoms, you do want to stop and you do want to treat them appropriately. If patients do not have withdrawal presentation, then you can likely move forward with the patient receiving naltrexone. As I mentioned earlier, naltrexone is an opioid antagonist. It does have competitive antagonist activity. It has little agonist activities. There are multiple thoughts in terms of how does Vivitrol help with alcohol and opioid use disorder. One of the thoughts is that as an antagonist, it can block opioid receptors, so it reduces the exogenous reaction to opioids, such as the pleasure response. Additionally, Vivitrol can modulate the expression of alcohol's reinforcing effects in the pleasure pathway. Next, we'll go into administration and storage of Vivitrol. This medication is recommended to be only administered intramuscularly and only into the gluteal muscle for optimal absorption. I'll discuss this more later, though essentially Vivitrol does come in a carton with supplies, and it's important that patients only receive the medication, only use the supplies that are provided to them. You do want to avoid other routes of administration, such as IV, sub-Q, and administration to the fatty tissue. If patients do have administration into these areas, that increases the risk for unpredictable responses, as well as increase the risk for injection site reactions. As with any injection, you do want to alternate sites, so in this case, you would alternate the sites on the buttocks. For the unopened kit, in terms of storage, you can refrigerate the contents. You can also keep it at room temperature for 7 or less days before you use. Additionally, this medication does have to be reconstituted, and so you do want to administer immediately, and I'll go over those steps shortly. Shown on the left are the 2 different needle sizes that are available. There's the 1.5-inch needle that's provided and the 2-inch needle. Who's appropriate for which needle? Typically, patients who are considered lean, like a BMI between 18 to 25 or so, may be appropriate for the 1.5-inch needle, and those with a larger body habitus, you would typically use a 2-inch needle. It's also important to note that this medication must be prepared and administered by a healthcare provider. This cannot be self-administered by a patient. For this slide and the next couple of slides, I'm going to break down essentially the steps for Vivitrol administration. As I mentioned before, Vivitrol does have to be reconstituted, but there are a couple of steps that are required before doing so. The first step is removing the carton from the refrigerator. You do want to allow time for the contents to reach room temperature. Typically, this takes around 45 minutes to do so. Next, you want to tap the vials on a hard surface. So if you look on this image on the left, you can see that the vials are being tapped. This includes both the Vivitrol powder as well as the diluent that's needed for reconstitution. Following that, you do want to remove the caps off both vials. You do not want to use the vial if the caps are broken or missing. Additionally, as you may already know, you do want to clean the vials with an alcohol swab. And after that, as you can see on the right of this image, you want to place the 1-inch preparation needle into the syringe and withdraw 3.4 mLs of the diluent from the vial. There will be some diluent left over in the vial because it comes in a 4 ml vial. Next, after that, you are ready to reconstitute. So what you want to do is you want to eject that 3 ml diluent from before, and you inject it into the Vivitrol vial, which again comes as a powder. If you look here on the image on the left, you can see that the content in the syringe is being injected into the vial. Next, after that, you do want to mix the vial, which again now contains the powder and the diluent, and you do want to give it a good shake. Now, what should the contents look like? The suspension should be milky white and be absent of any clumps. Now, after you reconstitute, you do want to withdraw 4.2 ml of the suspension into the syringe using the same preparation needle. If you look here on this image, you can see that the vial is inverted with the syringe inserted into the vial. After that, you do want to select the appropriate needle. Again, it's either the 1.5-inch or the 2-inch needle based on the patient's body habitus. Before you administer the injection, you do want to remove the preparation needle and then use the appropriate needle that you will use for administration, either the 1.5 or the 2-inch needle. Then, as you can see here, looking on the image on the left, you do want to peel the blister pouch and then grip the base and essentially attach the lular to the syringe. After that, you do want to seal the needle on firmly, and both the 1.5 and the 2-inch needle, they do come with protection devices. After that, you do want to move the sheath away from the needle, and then you do want to pull it, but you don't want to twist it because that can loosen the needle. And the last step in this process is you do want to make sure there aren't any air bubbles in the syringe, so you can push the plunger a little bit up to remove any air bubbles that may be trapped. After you've done all those steps, you are ready to administer Vivitrol. As you may know, you do, of course, want to clean the site of injection. As I mentioned before, this is particularly into the gluteal muscle. You can see here, looking at the gray, that typically it's into the outer portion of the gluteal muscle. And then again, you do want to alternate the butt administration sites. Additionally, you do want to aspirate for blood before injection to ensure that you are not injecting to any blood vessels. The way you can do that is when you inject, you can pull the syringe out just a couple of inches, wait a couple of seconds, and see if there's any blood in the syringe. If there is blood, you do want to not administer, and you do want to try administering on a different site, and then again check for aspiration. Once you do all of that, you are ready to administer Vivitrol. And again, this is only intramuscular and only into the gluteal muscle. After you administer Vivitrol, you do want to use the protection needle and cover the needle with the protection device and then dispose of properly. This image here is to summarize the contents that come in Vivitrol. As you can see here, if you look on the top right with A, that is the diluent. And then if you look for B with the blue cap, that is the Vivitrol powder. Additionally, we get 2 of the 1.5-inch needles and 2 of the 2-inch needles, as well as preparation needles. Some things you can look for is what should the powder and the diluent look like. The Vivitrol is an off-white to tan powder, and the diluent comes as a clear, colorless solution. Now, I know there's a lot of information, and I understand it can be hard to understand the steps as I walk through them. So I do have a video that will play for a couple minutes that will walk through administration. And for those who are in person and online, and if you want the video for reference, you can scan the QR code. This is a video that is on the manufacturer's website.
take you step by step through best practice instructions for the proper administration of Vivitrol.
Before I continue, can those online hear the video?
Yes.
Okay, perfect. I'm just going to jump ahead to the administration. This will play for a couple of minutes.
Section 2, Dose Preparation. The first step in reconstitution is to carefully tap the Vivitrol microspheres vial on a surface, as demonstrated here, to help the powder mix and move more freely. Now, remove the flip-off caps from both the microsphere vial and the diluent vial. And remember, never use the product if the flip-off caps are broken or missing. Once the caps are off, wipe the vial tops with an alcohol swab. The next important step to take in the process is to use your 1-inch 20-gauge preparation needle for Vivitrol reconstitution. The preparation needle is not for administration, but is the first step in dose preparation. Next, place the 1-inch preparation needle on the syringe and withdraw 3.4 milliliters of the diluent from the vial. It's typical for some diluent to remain in the vial. Now inject the 3.4 milliliter of diluent into the Vivitrol microsphere vial. To mix the powder and diluent effectively, vigorously shake the vial for about a minute. Be sure the dose is thoroughly suspended before moving to the next step. If you've mixed the suspension thoroughly enough, it will look milky white, have no clumps, and it will move freely down the walls of the vial. Immediately after the suspension step has been properly completed, withdraw 4.2 milliliters of the suspension into the syringe using the same preparation needle. Now, let's review in detail the administration needles to be used. Correct needle selection will help assure a deep intramuscular injection. Choose either the 1.5-inch or 2-inch 20-gauge Terumo needles based on the patient's body habitus. The first set of Terumo needles are 20-gauge 1.5 inches in size and may be best suited for very lean patients. The second set of 2 Terumo needles are 20-gauge 2 inches in size for patients with more subcutaneous tissue overlaying the gluteal muscle. This needle may be used to help ensure Vivitrol reaches the muscle tissue. 2 of each needle size, including 1 spare in each size, are supplied in each single-use carton in case of clogging. Either needle may be used for patients with average body habitus. After the withdrawal of 4.2 milliliters of the suspension into the syringe, remove the preparation needle and replace it with the appropriately selected administration needle for immediate use. Section 3. Administration needle placement. Next, to place the selected administration needle, peel open halfway the blister pouch of the selected administration needle. Grip the base of the needle, not the safety sheath. Attach the lure connection to the syringe with an easy clockwise twisting motion. Sit the needle firmly on the needle protection device with a push and clockwise twist. After this is completed, pull the safety sheath away from the needle and toward the syringe barrel. Do not twist, as it could loosen the needle. Prior to injecting, tap the syringe to release any air bubbles, then push gently on the plunger until 4 milliliters of the suspension remains in the syringe. The suspension is now ready for immediate administration. Section 4. Dose administration. Using a circular motion, clean the injection site with the alcohol swab. Let the site dry before injecting. For patient protection, do not touch the site again before giving injections. Vivitrol must only be administered as a deep intramuscular gluteal injection. You are now ready to administer the suspension by deep intramuscular injection into a gluteal muscle, alternating buttocks per monthly injection. it's important to inject the suspension in a smooth and continuous motion. Remember to aspirate for blood before the injection. Should blood aspirate or the needle clog, do not inject. Instead, change to the spare needle provided in the carton and administer into an adjacent part of the same gluteal region. Again, aspirating for blood before injection. Section 5. Sharps disposal. With safety always a priority, after the injection is administered, cover the needle. Do this by pressing the needle protection device against a flat surface, using a one-handed approach to activate the safety mechanism away from yourself and others. Keep the environment safe and clean. Always dispose of used and unused items in proper waste containers.
All right, hopefully that video gave you a sense of what the administration is like. All right. With all that information, we have our second active learning question, and that is relative to Vivitrol, which of the following statements is true? Is it A, reconstitution is not required prior to administration? B, injection can be self-administered? C, injection can be administered into the gluteal muscle via the IM, sub-Q, or IV route? Or D, injection should only be administered into the gluteal muscle via the IM route? All right. Yeah, so D is correct. Again, you do have to reconstitute. And again, it cannot be self-administered. It does have to be administered and prepared by a healthcare professional. Now, with that information, I'm going to transition into talking about contraindications, side effects, and monitoring. As you can see here, there are a variety of contraindications with Vivitrol. This includes hypersensitivity. And hypersensitivity refers to hypersensitivity with the active ingredient, inactive ingredients, as well as the contents of the diluent. Other contraindications include physiological opioid dependence or current use of opioid analgesics, as well as acute opioid withdrawal. Additionally, a contraindication is failure to pass the naloxone challenge or have a positive urine screen for opioids. Again, because of that risk for precipitated withdrawal. This slide here is a summarized warnings and precautions with Vivitrol. Starting in the top left, one of the warnings you want to look out for are suicidal thoughts and depression. This has primarily been reported post-marketing. Some studies have reported around 10% of patients have depression, whereas other studies have reported 0%. Suicidal thoughts and attempts are relatively uncommon, around less than 1%. You also want to be cautious in using in patients that have bleeding disorders or on anticoagulant therapy. Additionally, you do want to be cautious with use in patients that have hepatic and renal impairment. I'll go into a little bit more detail later on, but there's generally limited data in patients that have severe renal or hepatic impairment. In terms of the optimal duration, we don't really have a lot of information on how long should patients be on Vivitrol. Additionally, patients are to stop Vivitrol. There is no taper required because it is an opioid antagonist. As I mentioned before, you do want to ensure patients have the appropriate opioid-free period to avoid the precipitated withdrawal. Additionally, you do want to supply the patient with naloxone in case there is a concern for opioid overdose. For pregnancy and breastfeeding, we do have generally limited data, as most of the time this is an exclusion criteria in clinical trials. Both naltrexone and the main active metabolite, 6-beta-naltrexone, do cross the placenta. Generally, it's recommended to consider an alternative if that's an option. Additionally, for breastfeeding, both naltrexone and the main metabolite are present in breast milk. For this slide and the next couple of slides, I'm going to walk through the 4 significant adverse effects that are noted on the drug label. As you can see here, this is broken into the overview, mechanism, onset, and risk factors, and the significant adverse effects will be shown on the left. The first one is accidental opioid overdose, which can, of course, be life-threatening. How does this happen? Because naltrexone is an opioid antagonist, you do block the opioid effects, and so there is an upregulation of the receptors. The onset does vary, but one of the risk factors are missed doses of Vivitrol. The next significant adverse effect is hepatotoxicity. In most of the studies, there is acute increase in liver enzymes that do typically resolve. This can include increase in ALT and AST. Typically, this is dose-related. In terms of the timing, typically this increase in ALT and AST occur within 30 days. Some risk factors include older patients, which are typically greater than 50 years of age. The third significant adverse reaction are injection site reactions. As you would expect with any injection, there can be some reactions like pain, tenderness, bruising, redness at the site. There are some more serious adverse effects you want to be aware of, which include abscess, cellulitis, and hematoma. Why would these serious adverse injection site reactions occur? Primarily, that's due to improper preparation as well as improper administration, such as into sites that are not into the gluteal muscle. Typically, these injection site reactions can occur within the first couple of days after administration, but can occur into the days following. The fourth significant adverse reaction are precipitated withdrawal. Again, as I mentioned, you wanted to monitor for signs and symptoms in patients. This can include abdominal pain, agitation, confusion, diarrhea, anxiety, palpitation, etc. In terms of the onset, typically this can happen within a couple of minutes, but can peak within a couple of hours. Usually it resolves within 3 or so days. This slide here is to summarize the adverse effects that are documented to be greater than 10%. If we look on the top left, starting with cardiovascular and going clockwise, we have some effects including syncope. We have nervous system reactions such as anxiety and asthenia. Asthenia is essentially low energy and fatigue. We have neuromuscular adverse reactions like arthralgia and arthritis, respiratory like pharyngitis. As I mentioned before, we do have the concern for injection site reactions as well as increase in liver enzymes. And there's also some GI-related adverse effects like abdominal pain, diarrhea, nausea, and vomiting. Now, for those pharmacists in the room, you may be interested to know about drug interactions. The drug interactions are centered around opioid-containing medications. This can include opioid analgesics, which are contraindicated, those cough and cold remedies that contain codeine and hydrocodone, for example, and other medications that do contain opioids like antidiarrheal preparations. You do want to avoid Vivitrol in patients that are using opioid agonists. To summarize the monitoring parameters for the liver function test, it's recommended to get those tested at baseline and then periodically. Again, you do want to constantly monitor patients for opioid withdrawal. It's also recommended to get a baseline pregnancy test. Continue to monitor for injection site reactions, and again, monitor patients' mental status to monitor for depression or signs of suicidal thinking or attempts. For the nurses in the room, these next bullet points are essentially summarizing some key practice points, which include checking the labs, looking at abnormalities, again, monitoring patients' behavior, looking for withdrawal, and continue to monitor for injection site reactions or other adverse effects. With that information, we have our next active learning question. This is a case. We have a patient, KT, a 35-year-old female, presents to her outpatient doctor. She states she heard about an injectable naltrexone and asks if she can start the medication for her opioid use disorder. She also inquires about a medication for a recent cough. Which of the following is the most appropriate response? Additionally, her past medical history is notable for hypertension, major depressive depressive disorder and opioid use disorder. Her current medications are amlodipine 10 milligrams daily and sertraline 150 milligrams daily. Her labs are notable for ALT of 45, AST of 40, and creatinine of 0.8. Now, with all that information, how would you respond? Would you assume A, the patient is a candidate for Vivitrol and administer immediately? B, recommend starting Robitussin AC for KT's cough alongside starting Vivitrol? C, consider the patient an appropriate candidate for Vivitrol and recommend assessing additional factors, which include pregnancy and recent opioid usage? Or D, recommended again starting Vivitrol based on the patient's recent labs? Yes, C is correct. The reason A is not correct is you do want to gather more information before you recommend starting this medication. B is incorrect because Robitussin AC is a combination of codeine and guaifenesin, which is a contraindication for Vivitrol. D is not correct because the patient does not have abnormal renal or hepatic function. C is correct because the patient may be appropriate to start, but you do want to get additional information, such as, is the patient pregnant? Is the patient using opioids? Because if that's the case, you do want to ensure, again, that opioid-free period. With that, I'm going to go into a little bit more information about Vivitrol, and then I'll transition to going over key literature. Just a little bit about the pathophysiology of AUD and OUD. AUD is acutely associated with an increase in dopamine. Dopamine is a neurotransmitter that's commonly associated with this reward pleasure pathway within the brain. Additionally, there is an acute increase in GABA as an inhibitory neurotransmitter, and a decrease in glutamate, which is an excitatory neurotransmitter. However, over time, there are changes in both the neurotransmitter and receptor activity. With chronic usage, there can be a reduction in dopamine as well as a downregulation of receptors. For opioid use disorder, there acutely, again, is that increase in dopamine that's associated with this reward pleasure pathway and a decrease in GABA. Similar for AUD, with chronic usage over time, there can be receptor desensitization as well as receptor downregulation. I mentioned a little bit before about kidney and liver function. For patients that have normal kidney function as well as patients on dialysis, typically, dose adjustments aren't necessary. Again, we do have limited data. Oh, something happened. No, but I can press it. Thanks for waiting. We're having some internet issues.
I apologize, we're having an internet issue in the Winklestein conference room.
What? I'm not sure it's a good thing, though. Saturday, 73 and partly sunny. Sunny, or Sunday, kind of partly sunny. Monday. Yeah, Tuesday you go. I know. Hopefully it's sick. I hope so. I feel like more every weekend.
All right, folks, we are back. I'm just going to the slide we were on.
You think everybody left in or not?
Okay, we're back. Thank you, everyone. All right, so just circling back to renal function, generally we do have limited data because most patients and studies were excluded with severe renal impairment. However, naltrexone and its active metabolite are excreted renally, so generally you do want to use cautiously in patients that have severe renal impairment. For liver function, the recommendations do vary if the liver impairment was prior to starting naltrexone or if liver impairment was already in patients receiving naltrexone. So if we look here on the top part of the screen, for liver impairment prior to naltrexone, if patients have acute liver injury, like hepatitis, it's recommended to not initiate therapy. If patients have a Child-Pugh class A through C, typically no dose adjustments are necessary. For liver impairment in patients that are already receiving naltrexone, typically you don't need dose adjustments with chronic progression of liver impairment. However, if there's an acute worsening, typically you'd want to consider stopping the medication, and then you could consider restarting once there is resolution. Just a little bit about the pharmacokinetics of Vivitrol. As I mentioned before, the duration is every 4 weeks. This is different than the oral naltrexone, which is daily. One of the benefits of the intramuscular injection compared to oral is with the intramuscular you avoid those daily fluctuations in the peaks and the troughs. As I mentioned before, 6-beta naltrexone is the main active metabolite. Additionally, since Vivitrol is an intramuscular injection, we do bypass first-pass metabolism. Half-life is typically around 5 to 10 days. There are 2 different times to peak. Typically, the first peak is within the first 2 hours, and the second peak is typically 2 to 3 days later. Typically, the concentration starts to decline around 14 days after administration, and then it levels off for the duration of the 4 weeks. Additionally, Vivitrol and its metabolite are primarily excreted renally. With that, we have another question, and that is, which of the following statements are true? This is a select all that apply question. Is it A, patients likely do not need dosage adjustments with renal impairment? B, patients who develop acute liver injury after Vivitrol initiation may need interruption of therapy? C, AUD and OUD are associated with changes in dopamine? And or D, naltrexone is primarily excreted hepatically. What does everyone think? Okay, we have a B and C. Any other thoughts out there? All right. So the answer is A, B, and C. As I mentioned before, typically patients don't need adjustments with renal impairment, but you do want to use cautiously because Vivitrol is excreted renally. B is correct, because again, you may want to consider interruption of therapy with acute liver injury. C is correct because both AUD and OUD are associated with acutely increasing dopamine, but typically that decreases with chronic usage. D is incorrect because naltrexone, as I mentioned, is primarily excreted renally. Now, with all that information about Vivitrol, I do want to summarize two primary literature that influenced the FDA approval of Vivitrol. I'm first going to talk about a pivotal trial that led to the approval for Vivitrol for alcohol use disorder. This was a study that was published in 2005. This study was a 6-month randomized double-blinded placebo-controlled study. This was a multi-center study that took place in the United States at multiple sites, including hospitals, VA clinics, and other sites. The study looked at the efficacy and safety of 2 different dosages of naltrexone and looked at that relative to placebo. For the intervention, patients received the long-acting naltrexone Vivitrol alongside psychosocial intervention, and this was looking at patients with alcohol dependence. I'm going to go over some key inclusion and exclusion criteria. I won't be going over all these. I just want to highlight a couple of key points. Patients were included in the study if they were male or if they were non-pregnant, non-lactating female. Additionally, patients were included if they had alcohol dependence. Now, the reason it's alcohol dependence is at the time of the study, this was a DSM-4 criteria that used alcohol dependence and alcohol abuse. However, now we refer to alcohol use disorder as that's the updated DSM-5, which combines alcohol dependence with alcohol abuse. Additionally, patients were included if they had at least 2 heavy drinking episodes every week within the 30 days before screening. For men, it's a higher threshold of at least 5 drinks a day, and for women, it's 4 or more. Some key exclusion criteria, again, include signs of liver impairment. Additionally, generally, patients were excluded if they had major depression or had psychosis or bipolar disorder. However, patients were included if they had stable pharmacotherapy management. Additionally, patients were not included if they had the use of opioids, oral naltrexone, or disulfiram 2 weeks before screening. As shown on the bottom left in the gray box, patients were not required to abstain from alcohol in order to be in the study. As I mentioned before, the intervention included 2 different dosages of naltrexone. This includes the FDA-approved dosage of the 380 milligrams. The other dose looked at was 190 milligrams, and then other patients were in the placebo group. In terms of the frequency, patients received injections every 4 weeks for 24 weeks, and all patients were offered supportive therapy management. This slide here to summarize the primary and secondary outcomes. So looking on the left, the primary outcomes look at event rates of heavy drinking over 24 weeks of treatment. What does event rate mean? Basically, event rate is you take heavy drinking days divided by the number of days at risk for heavy drinking. Essentially, what the authors want to determine was to determine if the dosages of naltrexone decreased the number of heavy drinking days compared to placebo. Some key secondary outcomes include risky drinking days, as well as serious adverse effects, such as those that led to hospitalization. For statistical analysis, this was an intention-to-treat design, and a p-value of less than 0.05 denoted statistical significance. For this slide here, in the next couple of slides, I showed screenshots of the data in the study. I know it's a lot of information to process, so I'm just going to summarize the information on the purple box, but we can always go back to the data if you're interested. Some of the key baseline characteristics are that most of the participants were white men, typically around 45 years of age. The mean heavy drinking days was 20 days, and the majority of patients received all of the injections as part of this study. For adverse effects, the most common adverse effects were headache, nausea, and fatigue. As you would expect with injection site reactions, there was tenderness that was reported. There were some patients that discontinued the injections due to site reactions. This wasn't very common, but it was more common in patients within the 380 milligram naltrexone group. Additionally, there were some serious adverse effects reported, again, not very common, around 5% in the 380 milligram group, but that was the most common group that had serious adverse effects. For primary and secondary efficacy, essentially what naltrexone showed in a 380 milligram group, that there was a 25% reduction in heavy drinking days compared to placebo. This was statistically significant. So one way to look at this, if you look on the red box that says primary outcome, look at the hazard ratio of 0.75. Basically what this means is, since it's less than 1, this equated to a 25% reduction compared to placebo. And because the confidence interval, which are the numbers in parentheses, because those do not cross 1, that means those results are statistically significant. Additionally, patients who were abstinent prior to the study did have a greater reduction in terms of heavy drinking days. Now, I know it's a lot of information, so I do just want to summarize some key takeaways from this study. The primary outcome showed that long-acting injectable in combination with psychosocial management can reduce heavy drinking days. Again, patients were not required to abstain from alcohol, but they did have greater outcomes if they did so. There are some limitations. Again, patients' motivation in clinical trials can differ than what we see in real life. The main takeaway of the study is the results of this trial provided support for the FDA approval of Vivitrol for alcohol dependence, and then later on for alcohol use disorder. Now, with all of that, I have a question based on the literature I just shared, and that is, based on the study, which of the following statements are true? This is another select all that apply question. Is it A, patients were required to abstain from alcohol use and were excluded for actively drinking? B, psychosocial treatment was provided to patients who only received IM naltrexone? C, patients treated with IM naltrexone 380 milligrams reported a 25% decrease in heavy drinking days compared to a placebo? And or D, patients who received naltrexone 380 milligrams and abstained from alcohol had greater reductions in the number of drinking and heavy drinking days compared to placebo? What does everyone think? All right, we have a C and D out there. Any other thoughts? All right, let's see. Yes, good job. It is C and D. A is not correct because the patients were not required to abstain from alcohol. B is not correct because all patients, even if they were in the placebo group, were offered psychosocial treatment. C and D are correct based on the previous information that I shared in terms of statistical data and the abstinence data. With that, I have one more study to talk about, and then we'll transition to the end of the presentation. So I wanted to highlight a study that was pivotal for Vivitrol's approval for opioid use disorder. This is a study that was published in 2011. For the design, similar to the other study, this was a randomized, double-blind, placebo-controlled trial that took place over 24 weeks. This was a multi-center study that specifically took place in Russia. The purpose of the study was similar to the others. It was looking at efficacy and safety, as well as patient-reported outcomes. The intervention, again, was Vivitrol. Patients also received psychosocial support. And again, patients were included if they had opioid dependence. Again, just to highlight some key inclusion and exclusion criteria, patients were included. Again, they had the opioid dependence disorder, which again is now opioid use disorder based on the updated DSM. Additionally, patients were required to be off opioids for at least 7 days to avoid the precipitated withdrawal. The exclusion criteria is similar to the other study. Patients were excluded if they had liver impairment or if they were dependent on any other substance. For the intervention, patients either received the naltrexone 380 milligrams or placebo. Additionally, patients received the interventions every 4 weeks, and patients were offered naltrexone after the study. Similar to the other study, patients did receive supportive counseling. For the primary outcomes of this study, the primary outcome was response profile of confirmed abstinence. Response profile refers to the opioid-free weeks, and abstinence refers to a negative urine test or no self-reported opioid use. Some key secondary outcomes include the self-reported opioid-free days. There's also different scores that were looked at, including cravings and adverse effects. The key statistical analysis were the same. This was also an intention to treat study, and a p-value of less than 0.05 also denoted statistical significance. Similar to the other study, I'm just going to summarize some key data that's shown in the purple box. The baseline characteristics in the naltrexone and the placebo group were fairly similar. Most of the participants in the study were young white men, and additionally, most patients did receive the injections. In terms of the clinical outcomes, some of the main takeaways are essentially patients in the naltrexone group did have greater outcomes in terms of improvement relative to placebo. This can include greater confirmed abstinence days and weeks, as well as greater opioid-free days and retention, as well as a reduction in cravings. For adverse effects, patients generally reported tolerating naltrexone. There was some injection site reactions around 5%, but there were a few serious adverse effects that were reported. The key takeaways of this study is patients who were opioid dependent and they received IM naltrexone did have more opioid-free weeks than those in the placebo group. Overall, patients did tolerate naltrexone, and again, patients did have to be detoxified before they could be in the study. Some limitations, because patients could self-report their opioid usage, that is a general limitation in studies. The main takeaway is that this study showed that Vivitrol can help patients in reducing their cravings, as well as reducing their opioid usage over time. Now, with all of that, we have reached, I think, our last active learning question, and that is, based on this study, which of the following statements is true? Is it A, there was a higher percentage of opioid-free weeks in the IM naltrexone group compared to placebo? B, majority of patients were 50 years of age and older and primarily women? C, patients were required to be off opioids for at least 3 days? Or D, patients received IM naltrexone every 2 weeks? Yeah, just one is correct. What are we thinking? All right, we have some votes for A in the crowd. Yes, good job. A is correct. The reason B is incorrect, because again, most patients were around 29, 30 years of age, and most of them were men, not women. C is incorrect, because patients were required to be off opioids, but it was out for 7 days, not 3 days. D is incorrect, because patients received naltrexone every 4 weeks, not every 2 weeks, so good job. Now with that, before I conclude this presentation, I have a brief discussion about xylazine, as that was requested content to share. So I'm going to show just a brief video, and then we'll wrap up this presentation. So I'm going to play the video, and for those online, please put in the chat if you cannot hear it.
A powerful sedative, not intended for human use, is infiltrating the U.S. illegal drug market. The drug is called xylazine, or its street name, Tranq.
Xylazine is a non-opioid sedative. People who use drugs may unknowingly be exposed to xylazine. Xylazine might be mixed into illegal drugs like cocaine, heroin, and most often fentanyl, either to enhance the effects of the drug or to increase the street value by bulking up the weight. In a recent study, xylazine was increasingly found or detected among deaths involving illegally made fentanyl.
Xylazine is usually injected, but it can be used by swallowing, smoking, or sniffing it. Illegal drugs such as cocaine, heroin, and fentanyl can be mixed with xylazine. People who use drugs may not be aware of the presence of xylazine.
There are serious side effects to using xylazine, including sedation, difficulty breathing, dangerously low blood pressure, slowed heart rate, and injection wounds that can become infected.
In the event of an overdose, naloxone will not reverse the effects of xylazine. However, because xylazine is most often found in opioid drug products, mainly fentanyl, naloxone should still be given. It's important to call 911 for help, especially since the effects of xylazine may continue after naloxone is given.
In the event of an overdose involving xylazine, first responders recommend rescue breaths, especially for adults because xylazine can cause breathing to slow down. To give rescue breaths, make sure the person's airway is clear. Place one hand on the person's chin, tilt the head back, and pinch the nose closed. Place your mouth over the person's mouth to make a seal and give 2 slow breaths. Watch for the person's chest, but not the stomach, to rise, and follow up with 1 breath every 5 seconds. For more information on xylazine and what communities and families can do, please visit www.cdc.gov/drug overdose.
All right, I know that's a little bit of an aside from Vivitrol, but some of y'all may have actually encountered patients using xylazine. And for those in the room, I do have a box you're welcome to look at later. There's xylazine test strips that you can use to see if a substance that patients may use contains xylazine. So this is something that you may want to consider using or discuss with your patients if that's appropriate. This slide here, again, is just to summarize what was over in the video. Again, xylazine is an animal tranquilizer. It's not approved for human use. There are a variety of concerns you want to have include unexplained wounds. If patients do present to the hospital and do have xylazine withdrawal, typically you'd want to consider treating with clonidine because xylazine and clonidine are structurally similar as they're both alpha agonists. Now, with all that information, coming to the end, I just want to return to this question I asked about the beginning, and I encourage you to think about if your level of comfort and knowledge has changed when it comes to Vivitrol following this presentation. In summary, both alcohol and opioid use disorders are prevalent, and again, naltrexone, Vivitrol is approved for both disorders. Vivitrol is a long-acting intramuscular injection, again, only for the gluteal muscle. And of course, you do want to look at all patient factors to consider if a patient is an appropriate candidate. As literature shows, Vivitrol can help patients with their alcohol and opioid use disorder. So with that, here are my references. I do have a QR code if you would like to share your feedback. It's just a brief anonymous survey to share how you feel like the presentation went. I love feedback, so I appreciate it. If you have any feedback, you're welcome to scan the QR code or use the link at the bottom. But it is, again, completely anonymous. So with all information, I will take any questions or comments that those online or those in person have.
Thank you. That was really, really good and complete. I'm wondering, is there, and I'm not sure